Welcome back, everyone. I am so incredibly excited to have you here for part 3 of our 15-part Interventional Radiology Coding Masterclass Explainer. If you've been following along with us, you know we've been unraveling the mysteries of some seriously complex healthcare topics, just breaking them down so you can totally master them in your day-to-day work. Well, today, we are heading straight into the vessels. We're going to tackle a foundational concept that, honestly, trips up so many people, from absolute beginners all the way to seasoned veterans, and that is the critical difference between diagnostic and therapeutic vascular procedures. Because let me tell you, getting this wrong, it can completely derail your analysis of an operative report. So grab your notes, get comfortable, and let's dive into this and make this complex topic incredibly clear.
Here is our agenda for today's explainer. First, a welcome to Part 3. Then, we'll cover diagnostic vascular procedures, followed by therapeutic vascular procedures. Next, we'll bridge into the coding connection. And finally, wrap things up with a recap and next steps.
All right, Section 1, welcome to Part 3, Setting the Stage.
So, interventional radiology, or IR, it's just this incredibly fascinating field that has completely revolutionized modern medicine. Unlike traditional same-day surgeries, the ones that historically had to rely on large, open incisions and meant really long recovery times, IR is fundamentally defined by its minimally invasive approach. Physicians rely heavily on real-time imaging techniques. We're talking X-ray, fluoroscopy, ultrasound, CT, and MRI to constantly guide their instruments inside the patient. Honestly, you can think of them as high-tech plumbers for the human body, using a live high-definition GPS system to perform highly complex diagnostic and therapeutic procedures. And they do the whole shebang through tiny, pinhole-sized portals rather than large cuts. For a medical coder, this means the documentation you're reading won't describe massive surgical openings. Instead, it's going to describe a highly technical, image-guided journey right through the body's internal pathways.
So where exactly does all this magic happen? Well, it happens inside the human vascular system, which is an incredibly complex, interconnected network. In IR, we categorize this entire network into distinct groups that we call vascular families. It helps to think of these families as massive branching interstate highway systems. Up at the top, you have the intracranial arteries supplying the intricate structures of the brain, and the carotid arteries supplying the face and head. Then you have the coronary arteries feeding the heart muscle itself. As you travel downward, you drop into the visceral arteries, like the celiac and mesenteric arteries, which are responsible for feeding your critical abdominal organs. And finally, you reach the lower extremity arteries branching all the way down into the toes. Understanding and navigating these interconnected families, that is the true art of interventional radiology, and it is the exact roadmap you need to follow as a coder.
Moving right along to Section 2, Diagnostic Vascular Procedures. This is our core concept 1.
Let's look closely at how the diagnostic phase actually works. The primary focus here is simply mapping and identifying. To pull this off, physicians use a specialized technique called angiography. They'll carefully place a thin, flexible tube, called a catheter, into the vascular system and inject a specialized contrast dye. This dye brilliantly lights up the blood vessels on their live imaging screens, essentially creating a high-definition roadmap in real time. This allows the physician to identify specific pathologies. They're looking for things like severe blockages, narrowing stenosis, dangerous aneurysms, or abnormal malformations. For us coders, reading this part of an operative report is exactly like reading a detective novel. You are meticulously scanning the text, looking for the exact moment the physician identifies the culprit. It is a purely investigative mission to see exactly what is happening inside those tiny vessels.
So the absolutely crucial takeaway here is that when you see terms like angiographies and diagnostic catheter placements, you've got to recognize that the clinical intent is purely diagnostic. The physician is exclusively gathering information. They're actively detecting vascular conditions, they're carefully assessing the velocity of blood flow, and they're using all this vital data to plan future treatments. They are absolutely not actively fixing the problem during this specific step. The ultimate goal here is an accurate diagnosis, pure and simple. As a coder, you have to lock in on this intent. Because if the physician stops right here and removes the catheter without doing any repairs, your coding pathway is completely distinct from what happens if they actually decide to intervene.
Which brings us to Section 3, Therapeutic Vascular Procedures, Core Concept 2. Now, understanding the conceptual difference between these two is the key to everything we do in IR coding. On one hand, we have our diagnostic intent, mapping the structures, injecting the dye, finding the disease. But on the other hand, the goal shifts entirely to therapeutic intent,
This means the physician is rolling up their sleeves and actively treating, managing, or repairing the vascular condition they just uncovered. Very often in the real world, a diagnostic procedure serves as the mandatory prelude to a therapeutic intervention. The physician uses the diagnostic phase to map the road and find the pothole, right? And then they immediately pivot to the therapeutic phase to patch that pothole before ever leaving the vascular system. Let's break down some prime examples of therapeutic execution so you know exactly what active repair looks like when you're reading a report. If there's a severe narrowing in a vessel, the physician might perform an angioplasty, utilizing a tiny inflatable balloon to forcefully dilate the artery walls. They might follow that directly with a stent placement, where they deploy a tiny wire mesh tube to keep that vessel permanently propped open and restore healthy circulation. Now, if they encounter a dangerous, life-threatening blood clot, they might perform thrombolysis, which is slowly infusing medication to just dissolve it. Or, on the flip side, if there's a massive, active internal bleed, they might perform an embolization. That's where they deploy coils or specialized glue to intentionally block the vessel and immediately stop the hemorrhage. These are all active, physical repairs happening under precise image guidance. And as a coder, the second you see these therapeutic actions in a report, your whole coding landscape completely changes.
All right, Section 4, the coding connection, bridging clinical to coding.
So why does all this deep clinical background actually matter to you? Well, because distinguishing these intents is literally your primary job. Let's practice by reading through a real-world operative report like it's a story, just following the catheter's journey step by step. Let's say the report states, the common femoral artery was accessed using ultrasound guidance. Okay, that's our front door, our entry point. Next, a guide wire is carefully threaded in, followed by a catheter. The catheter is then smoothly advanced up into the massive abdominal aorta, where contrast dye is injected to take broad, high-level images. But the physician's journey doesn't stop there. They continue to navigate, advancing the catheter down into the left common iliac artery, and finally pushing it all the way down into the left superficial femoral artery for even more granular, detailed imaging. You have to track every single movement. And tracking that journey brings us to a golden rule of medical coding. The rationale you absolutely must memorize is final placements includes lesser first-order selection. Now, what exactly is a first-order selection? Simply put, it's the very first main branch a blood vessel takes off the main anatomical highway. It is exactly like taking the very first exit off a massive interstate. What this powerful rule means for you is that you code only for the furthest, most selective catheter placement. You do not separately code for every single temporary stop the physician made along the way. In our previous story, even though the physician stopped in the aorta and the common iliac to take a look, the final destination, the absolute deepest point of the journey, was the left superficial femoral artery. That single, final placement inherently encompasses all the lesser selections leading up to it. Applying this rule correctly is absolutely essential for keeping your coding clean, accurate, and completely compliant.
Finally, Section 5. Recap and next steps. Our summary and teaser.
Wow, we have definitely covered some major ground today. Let's just lock in these concepts with a quick, high-level summary. When you're analyzing a chart, always ask yourself, what is the primary goal here? If the answer is mapping and identifying, like performing an angiogram, well then you are firmly on the diagnostic side. You are dealing exclusively with the creation of the clinical roadmap. However, if the primary goal shifts to actively treating a repair, like deploying a stent or dilating a vessel with a balloon, you've crossed over to the therapeutic side. You are now dealing with the active execution of a clinical repair. Grasping this fundamental dichotomy will completely change the framework you use to read an operative report, and ensures you always capture the true nature of the procedure.
But hey, our journey into the vessels is far from over. Coming up in Part 4, we're going to get even more granular. We'll be diving deep into the mechanics of diagnostic angiography and catheter placement. We'll look at exactly how those delicate wires and tubes physically navigate the distinct vascular families, which is going to make coding those incredibly specific, complex procedures an absolute breeze. Until then, ask yourself, the next time you read an operative report, will you just be looking at a random list of blood vessels, or will you be tracking the true intent of the physician's journey? Thank you for watching, and keep learning with Decode Healthcare with Harshal.